Hello, my name is Wasim Anani. I am a medical officer with Canadian Blood Services and I work with the National Immunohematology Reference Laboratory. There are going to be three sets of videos, one for each of the tiered questions. This one is for tier one, and this is going to be a bit of a hybrid of a PowerPoint and a chalk talk. I'll be using my stylus to write on the screen, and hopefully this will help enhance the education content. I'm looking forward to it, and let's get started. We'll be starting with our first case, and remember the tier 1 cases are the baseline cases that are the easiest. However, there are some more difficult questions thrown in, so don't be too surprised when you see some hard questions. So we have a 24-year-old female that arrives for an outpatient surgical procedure, and a type-in screen is sent. So for this first question, let's take a look at what we have. We have our forward typing, and we have a 4 plus with an ANT-A and nothing with an ANT-B. Our reverse typing shows a 1 plus with an A1 cell, 4 plus with a B cell, and our RH typing with two different D reagents shows 4 plus and 4 plus. Our DAT is negative with the polyspecific reagent. So when we're looking at this and trying to answer the first question is ABO typing demonstrates a discrepancy in the blank. So when thinking about the discrepancy, we have to think about where obviously the discrepant reaction is. And most often texts will look at the strength of reactivity as an indicator, but the reality is you should really think about the forward and the reverse typing separately and think about whether or not they jive together. So in this particular case, the forward typing presents as a group A, the reverse typing presents as a group O. So the question becomes, which of these is the discrepant one? In this particular case, because the strength of this A1 is much weaker, you could argue that the group O typing is the one that is discrepant versus the group A typing. That's not always correct, but when you have to start resolving an ABO discrepancy, you have to pick a direction. You either have to pick the forward or the reverse typing in order to do your workup. And you'll see with my workflow later on that you have to pick a direction. You can't sit on the fence about it. And I think that's one of the most difficult things about an ABO discrepancy. You pick one of the two and then you work it up. You may be completely wrong and that's okay. But in this case, because the discrepancy appears to be most related to the A1 cell, we would say the reverse typing is a discrepant. For question 2, what is the first step in resolving the discrepancy? You can pre-warm, wash the patient's cells, review the antibody screen results, or increase the incubation time. So again, let's look at this. We have a forward typing which we think is correct, a reverse typing which we think is incorrect, and with this reverse typing, we have a few options, right? We can pre-warm it to see if it goes away. Washing the patient's RBCs won't do anything because that's really the forward typing bit. Reviewing the antibody screen results, we can do that. And increase the incubation time, we can do that. So these three things are the three things that we can do for reverse typing. If we were to pre-warm the plasma or serum, the question becomes, is the shotgun approach really worth it? So if you pre-warm a sample, you're not sure what you're pre-warming. Remember, you can pre-warm away clinically significant antibodies. And when you're doing a type-in screen, the whole point of doing the screen is to identify any antibodies that may interfere with your ABO typing. So in this particular case, you don't pre-warm unless you know what you're pre-warming away. Increasing the incubation time will likely not do much or make this 1 plus even worse. And so that'll just make it more confusing. And so the last one we have is reviewing the antibody screen results. Again, remembering that if you have an allo antibody or an auto antibody, it can interfere. But if you don't know that it's there, you can't really attack it. So the best way to go about this is actually just doing your antibody screen results, which you would usually do at the same time as your ABO typing if you've got multiple systems running. But in this case, we're kind of taking it in a stepwise format. So as I promised, we're going to talk about how to approach a forward and a reverse typing discrepancy. And this is after you've made the decision about whether the forward or reverse is discrepant. Remembering that you just have to pick a direction. You may not be right, and that's okay, but you just pick a direction and you go with it. So with a forward typing discrepancy, we really have three main things we can think about. An extra antigen being expressed, a missing antigen, so a loss of an antigen, or mixed field agglutination that throws us off. that we were not expecting. With a reverse typing discrepancy, we can have extra antibodies. So like we have in this particular case, we have 1+ reactivity with an A1 cell in an individual who is group A, and we would not expect that. Or we can have missing antibodies. So for example, if a group A individual did not have an anti-B in their plasma, we would be surprised by that. So for our forward typing, let's go through my thought process of how I approach it. So we have a forward type, and I'm sorry about my awful handwriting. We can have a missing or a weakened antigen, correct? And so from there, what I usually think about is a subgroup of A or B, or you can have suppressed antigen. The other side of a forward typing is you can have unexpected reactivity. And so you have an extra antigen you weren't expecting. So with this, there's a few options. You can have acquired B. So this, for example, occurs when someone with colon cancer releases the deacetylase enzyme, which then converts a group A individual to look like a group B individual by some monoclonals. That's much less seen nowadays than it was in the past, but it can still be seen. You can have this, which is essentially a B, which expresses a weakened form of A, and therefore it looks like it's an extra antigen, but the person really does express a group A, it's just weakened. You can have mixed field, and you can have antibody coating the cell, which blocks the antigen from being detected. And before I forget, if anyone ever wanted to know, this is called B sub A. So for our forward typing, we can have mixed or weakened, and we have subgroups that are A or B. We can have a suppressed antigen, and on the other side, we can have unexpected antigen. So we can have acquired B, we can have a B sub A mixed field, or antibody coating the red cell, which throws us off. So one of the more common types of discrepancies with forward typing is with the group A. And so I'm going to focus on that for the next 2 slides because it's the most common thing that we run into with A subgroups. So when thinking about A subgroups, they give us usually forward typing that's off and sometimes reverse type that's off if they form an anti-A1. But let's focus just on the forward typing. So if your forward typing reagent shows a weak with an anti-A reagent, and it's fully mixed field, we're talking about an A3, which is the most common subtype of the A's. If it's less than 10% mixed field, then we're talking about A end. If it's weak plus with an anti-A comma B, then we're talking about an AX. And you'll recognize these most often from textbooks, and the reality is, even though I've learned these serologically, a lot of it's done molecularly now, but serologically you can get pretty darn close to what it is. As long as you have a gentle hand and a good eye, you can detect the difference between a full mixed field and a 10% mixed field, and then the weak plus with an anti-A comma B. So now what happens with your A subgroups? If your anti-A shows nothing, well, now you have to actually start going into secretor status, which I'm sure many people love. Oops. So if you're a full secretor and you've got nice strength reactivity with your A and H antigens, and H being group O, then you're an AM. If your secretor status shows weak plus for A and H, now we're talking about A end. And if you secrete only the H, Now we're talking about AL. And the AL is the eluate version of A, so A is expressed on such a low level. You use an anti-A and it shows nothing, but you can elute off the anti-A because it's concentrated when you run the eluate, and that's when you can detect it. And so they only secrete H as a result of that because there's such low amounts of it. So with these are the A subgroups. There's no anti-A reactivity compared to the prior slide where there's weak reactivity with anti-A reagents. And again, you can identify these molecularly. They can be a little tough sometimes depending on the genotype, the type of genotyping you run. And so serologically, you can get pretty close to what the answer is. So now let's talk about what's going on in our case. We have a reverse discrepancy. So with a reverse discrepancy, you can have missing or weakened antibody. The other option is you can have an extra antibody appear that you weren't expecting. So with the missing or weakened, you have two options. You can have weakened anti-A in the patient's plasma or serum, or weakened anti-B. So pretty simple. With the extra antibody, we have a few. You can have an A subgroup, which means you have to run the A1 lectin because you have an anti-A1 present when you don't expect it in a group A individual. You can have an autoantibody, cold or warm. You can have rouleau, which is the stacking of coins, usually due to plasma proteins. And then you can also have a passive antibody. So for example, if someone receives a red cell unit with an alloantibody in it, it may show up. Or if someone receives something like IVIG and it tends to bind something that it shouldn't. So again, to go over our reverse typing discrepancies, we get a missing or weakened antibody. So for example, in a group B individual, you might have weakened anti-A. In a group A individual, you might have weakened anti-B, or in a group O, you might have missing or weakened anti-A or anti-B. For our extra antibodies, you can have an anti-A1, which you would identify with your A1 lectin. You could have an autoantibody giving you extra reactivity. Rouleau, which is the stacking, which is called stacking of coins when the red cells stack because of excess plasma proteins, or you can have a passive antibody due to some other introduction of the antibody to the patient. So the identified antibody is known to classically react at what temperature? So let's take a look at our antibody ID. We have immucore cells, and we have no reactivity in MTS gel in the first 5 cells here. And then the last 2 cells, 6 and 7, we have 3 and 2 plus reactivity. So if we look across, kind of making it a little bit easier, you can see that the texts have already kind of ruled out a lot of stuff. And really, if we just scan, we can see that the only antigen that's present that really only has 2 that are reactive is the M antigen. And so we have 3 and 2 plus reactivity matching with the anti-M. And we know that anti-M reacts classically at room temperature because it's a cold reacting alloantibody. So we're going to talk a little bit about the M alloantibody, and let's first discuss the serology. So it's predominantly IgM and cold reacting, which means it reacts at a predominantly immediate spin reactivity. It does show dosage, so if you're M positive, N positive, or M positive, you'll get, let's say, 1 plus reactivity here, and you might get 3 plus reactivity here. It's warm reacting. Oh, sorry, if it's warm reacting, it's usually an IgG component of anti-M. So for those cases where you've got immediate spin, 37, IAT, and you see 1 plus reactivity, let's say 1 plus reactivity and 1 plus reactivity, it's most commonly that this component is the IgM, this component is the IgG. So the anti-M can actually have multiple Ig isotypes depending on where it reacts. And they usually do not activate complement. Even the ones that react at IAT phase normally don't activate complement. Usually they cause hemolysis through delayed hemolysis. So they'll bind to the red cell and they'll be removed from the intravascular space by the reticuloendothelial system. So they don't cause intravascular hemolysis the way that, for example, ABO antibodies can. Sorry, I'm trying to get it to go next for me. There we go. We can use enhancement to help us out. So let me just erase this here. Oops. So if we're going to use enhancement to bring out the anti-M, you can use PEG, LIST, or polybrine. However, if you're using these techniques, you have to be really careful because if it reacts at an immediate spin, let's say it's 2 plus or 3 plus at immediate spin, at 37 in IAT, if you use your PEG, let's say, you can actually get reactivity that's like, let's say 1 plus, that kind of carries over because the PEG enhances it enough that it's able to react at a warmer temperature when it normally wouldn't. So just because it reacts at 37 does not mean it's clinically significant if you're going to run it in PEG. So if you're going to look at clinical significance of an anti-M, it should only be done in saline because you can trick yourself into thinking it's clinically significant based on this carryover effect of using an enhancement method of like PEG, LIST, or polybrine. You can drop the pH down to 6.5 to enhance an anti-M, and some anti-Ms only react in the presence of 1 to 2% glucose solutions in plasma. And we don't really know why that is, other than the fact that the glycophorin A protein is a glycoprotein which has sugars on it, and it may be that the sugar helps enhance the antibody binding to the actual protein itself. And then finally, clinical implications. If it reacts at greater than 37 degrees, it's more likely to be clinically significant, and therefore you should honor it. If you look in ICIT, it says that anything that does not react at 37 or above for an anti-M, they pretty much ignore it and they'll just give it even if it's quote cross-match compatible at a immediate spin. They also recommend not doing immediate spin cross-matches for these anti-Ms because it essentially just makes more of a headache for you. And then it very rarely causes HDFN. It can, but it very rarely does. And in cardiac surgeries, a lot of the times we get questions about what happens if we're going to put the patient in a hypothermic state. So they drop the temperature of the patient down to drop the heart rate in order to do their work and allow the heart not to be ischemic. Interestingly, they looked at patients with anti-Ms that were cold reacting only, and none of them caused hemolysis or that caused the delayed hemolysis. So really, these anti-Ms don't cause any issues even when the body temperature is dropped down. They're pretty much just a nuisance when they react only at immediate spin. For this next question, number 4, if a transfusion is needed and you have limited inventory, would you issue cross-matching compatible units based on the antibody identified? So now we have to think about what I had just talked about before, remembering that this antibody does not really cause hemolysis, and it's only reacting really at immediate spin. What would we do? Because it's not clinically significant, you can actually, especially in an emergency, issue and feel pretty darn safe. Now, if you're at a larger institution or if you have a ton of time, if you really wanted to, you could cross-match units to find an M-negative unit, remembering that about 75% of units are M positive. 1 out of every 4 will be negative, and so if you want to play it safe, you could find an M negative unit. But in this particular case, because it's an emergency and we need to be able to issue units and our inventory is limited, you just issue what you have on the shelf. M positive or M negative doesn't matter, and it will not cause hemolysis. Now, if you did a full serological cross-match, right, it potentially would show up if you did immediate spin, but remembering that I said it's a kind of a red herring, it tricks you because there's reactivity immediate spin, it's still okay to issue it. And it will show up in a full serological cross-match, so that would have been theoretically no. Is this antibody causes hemolysis? We know that it typically does not, and this antibody causes anaphylaxis? No, it does not. All right, so now that we've identified the alloantibody, remember that you form alloantibodies to things that you do not have on your red cells. Of course, there's exceptions to the rule, but for the most part, you form alloantibodies to things you don't have. This is also called the Landsteiner's law. So if you phenotype a patient's red blood cells, what antigens would you expect to be negative? Lewis A, Duffy A, M, or N? And our texts were kind enough to do the phenotyping. You can see the grading was negative with an M monoclonal, positive control was good, negative control was good. So this is a valid test, and we would expect that the patient would have no M antigen because they formed the alloantibody. So now back to our original question. We had an ABO discrepancy, and the most likely reason why we had a discrepancy was that the red cell that we were using that was an A1 likely expressed the M antigen, and the person had an anti-M. Therefore, we're getting that reactivity in this particular cell for the reverse typing. So now that we know that, we select a red cell reagent that is negative for our anti-M, and then in an emergency, you would expect the ABO typing to be compatible in the future without typing your reagents in advance. What would you use for your massive hemorrhage protocol? So again, we have a patient coming in, they're massively bleeding. Let's say they're at a new hospital, they don't have time to type their reagent. And we know from the past slides that anti-M reacting at immediate spin does not cause clinically significant hemolysis. And so you would essentially give your A positive, since we know the patient's blood group, and we would ignore the M in this particular case, and we would give M unscreened. So it would be C. The other thing to keep in mind is that even if the person had a clinically significant anti-M, remember they very, very rarely cause in vitro hemolysis or in vivo hemolysis, which means that you're not getting intravascular hemolysis. You're not putting the blood in and it doesn't hemolyze as soon as it gets into the person's bloodstream. It binds and then it gets removed later on. So if you happen to transfuse a unit or two that are incompatible, they're not going to be removed right away, and so be able to save the person's life because the red cells are going to survive for a day or two. Now the clinicians can go and do other things like apheresis if they need to get rid of it or support the patient until the units are cleared, but even if it was clinically significant, it would not cause an issue, especially in an emergency setting. You need to save the person's life in the moment, and that anti-M will not cause harm in the moment. So our second case is actually nothing to do with serology per se. It's reviewing the newest massive hemorrhage protocol toolkit that is available on ORBCon's website. So I've given you the link, and we're just going to run through a few questions. These will be pretty straightforward. So the first question is, you're preparing to update your massive hemorrhage protocol. An MHP should include a multidisciplinary team for A, and you can see I've removed this from the toolkit, and you can see it should be developed by a multidisciplinary team, including physicians from multiple hospital services, including emergency trauma, surgery, anesthesia, critical care, and then obviously non-physician personnel like blood transport, security, communication services, laboratory personnel, and they also suggested someone from respiratory therapy. For the second part of this, applicable only for level 1 trauma centers. That is false. I thought I had it. There we go. So the protocol should be tailored to each institution based on their current resources, and so therefore a one-size-fits-all does not actually work. So this one and this one are gone now, and should be reviewed every 5 years is not true. It should be reviewed every 3 years. So that should be 3. The answer is A. For the second question, the transfusion packs should include, so these are the coolers that you send out. So in each cooler, you have got the RBCs, plasma, and then plus or minus the platelet. So 2 units of RBCs, PCC, which is prothrombin complex concentrate if plasma is not available. Only 2 coolers unless the clinical team calls for more, and then continue no matter what the laboratory results come back. All right, so based on those choices, let's take a look at what's in the MHP toolkit. We can see for adults, they I'll start off with 4 RBCs. So that first one is out. We can also see that for massive hemorrhage protocols that can't provide plasma, they're actually providing PCCs. So that one is correct. If you don't have plasma, you should be offering prothrombin complex concentrate. And again, here it shows if you don't have enough to issue for plasma, you can substitute it for a PCC. And then for the final question on there was whether or not you would use laboratory values to guide your management, and the answer is yes, you should. So we use 4 RBCs for the most part based on the toolkit. You keep sending coolers until the clinical team calls you and tells you to stop sending coolers, right? Because the communication should be two-way the entire time. And you also want to stay ahead of the bleeding. And then you continue on and you start to modify what you're giving based on the laboratory results. So once you start getting laboratory results in, they may call and start modifying what the components are that the patient should be getting so that it's being tailored to what their bleeding is actually needing to in order for it to stop. So the correct answer is B. PCC can be used if plasma is not available. So question 3 gets at the use of Rh- versus Rh positive units in a bleeding person where you don't know the blood type. So we have a MHP going on, and we need to know what the appropriate pair of a person to the O-neg unit is most appropriate. And I pulled this image from the toolkit, and you can see any woman less than 45 years of age should receive O-neg. So off the bat, we can say that this 60-year-old man doesn't need it, and this 40-year-old man doesn't need it. And so now we're down to a 15-year-old woman and a 30-year-old woman. They're both less than 45. However, the 30-year-old woman has had a hysterectomy, which means she can't have a child on her own. And therefore, if she forms an anti-D, it actually won't cause harm to a fetus because she can't carry a child. And therefore, she can actually receive O-positive units, as long as you know that she has a history of a hysterectomy. And so then we're left with C being the answer. A 15-year-old woman should be the one to receive O-negs out of these options. For question 4, which of the following is not possible for a massively transfused patient? So when you're receiving large volumes of red blood cells, plasma, and platelets, cryo, and whatever else you're getting, remember that many of them are at colder temperatures. So there's something called the deadly triad. It's hypothermia, hypocalcemia, and dilutional coagulopathy. It essentially occurs because you're getting cold blood products, which drops your temp. And when you drop the temp, you actually decrease the effectiveness of your coagulation cascade. The enzymes require a certain temperature, so when they drop, you actually make clotting harder. Because there's citrate in the blood products, you can actually drop the calcium levels. So hypothermia, hypocalcemia, and then because you may be putting in saline, albumin, or more plasma than red cells, you can also dilute you can also drop the hemoglobin content and make them diluted, or you can also, just by giving them plasma, too many red cells or too much albumin, you can also drop the person's coag levels because you dilute their plasma too much. So either you can dilute the hemoglobin or you can dilute the plasma. Most often people refer to dilutional coagulopathy as the dilution of the plasma content and therefore a drop in the coag factors from unbalanced transfusions. And then finally, the INR of plasma once it's thawed is not 1. It's usually above 1.3. Somewhere between 1.3 and 1.7 is the average unit. So this is not possible. If you're transfusing plasma, even if you replace the entire blood volume of someone with plasma that's been freshly thawed, they would never be at an INR of 1. They'd be an INR of somewhere between 1.3 to 1.7. So they can be hypothermic, they can be hypocalcemic, and they can have dilutional coagulopathy. This is going to be our third and final case for Tier 1. So let's take a look at what we have. Question 1 is a 28-year-old woman presenting to the emergency department with fatigue and flu-like symptoms. She's diagnosed with AML with a hemoglobin of 65. The nurse informs you a few days later that the patient will be getting a stem cell transplant from a sibling that is B positive, and in order for 1 unit is placed of red blood cells, and since the patient's short of breath before starting chemotherapy, which blood group would you choose to issue for this patient? So in looking at this, let's just first look at the ABO typing, ABO and RH typing. Forward typing looks good. We have a forward typing of group A, reverse typing matches with an ATB. They're RH negative with 2 monoclonal RHD reagents, so therefore they are A neg. So we have a person who's, sorry, my handwriting is not great today. We have a person who's A neg going to be positive. And so we, in knowing that, need to think about what the patient's going to be getting red cell wise. Now, most institutions in Canada and the standard practice is actually you continue to transfuse based on the current blood grouping, and then you switch over when the transplant happens. There are some institutions, less commonly, and I've been a part of some of them, where if you are a neg, going to be pos, you actually think about this part when before you ever go to transplant. So in this particular case, we're going to think about what most people do, and which is probably what your institution does, which would be this approach. When the transplant happens, you stop and you switch over. So we're thinking about the patient who is A neg now, and so as a result, you would transfuse them with A negative units. Now, if you happen to be at an institution where you consider the conversion blood group, you'd have to think about what would be compatible with an A neg and a B pos. And the reason why some places do this is that if you transfuse an A neg RBC, and now they start making anti-A, right, because they're B positive, you can get hemolysis. So some places, as soon as they know someone's going to transplant, they will take into account both blood groups and then make the decision. If you're at an institution like this, you'd be giving O neg or O pos, depending on how strict you're going to be. So, however, for most institutions, it'll be A neg because you stick to the blood group, and then when the switch happens, so let's say transplant happens here, you then switch over to the O negative or O positive, depending on your institution. But for this particular answer, again, it's A negative. So the patient begins induction chemo, and now you notice a discrepancy. What is the explanation for the ABO discrepancy? So let's look back at our ABO. We have a forward typing of group A. Reverse typing shows AB individual. Since they have no anti-A or anti-B, they continue to be Rh negative, so they haven't fully engrafted, showing any Rh positive. So the question is, what's causing the discrepancy? So remember, we have a forward discrepancy and we have a reverse discrepancy. We have to decide which is which. Since we knew the historical, we know that it's not the forward typing, because the forward typing still types as a group A. What's odd in this particular case is that our reverse typing is now different, right? We used to have an anti-B, and it's gone now. So if we take a look at this, gain of A antigen on the red blood cell. No, we know that we haven't gained anything. Loss of A antigen on the red blood cell. No, because we can see it in the forward typing. Gain of anti-B in the plasma or serum. Obviously, we haven't had a gain since we have no anti-B, leaving us with D, loss of anti-B in the plasma or serum. Now, the next question, 2 weeks after chemotherapy and the stem cell transplant, a type-in screen is sent in preparation for a transfusion. What's the explanation for the mixed field RBC agglutination? So remember, this person started A pos, they got transplanted, so they're like in a black box, so to speak, and at some point they're going to come out as B positive. Excuse me, they were A neg. Ooh, let me change that here. They were A negative, going to be positive. So at some point in this black box, they're going to be A negative and B positive at the same time. which means that you have to take that into account, right? So in the last question, they had lost their reverse typing, right? And so they were just looking as group A forward, but their plasma cells weren't producing the anti-B. Now they're engrafting more. And so as a part of this A neg to B positive situation, we're starting to produce both A negative and B positive cells. And so now we're getting a mixed field. So in the forward typing, we have the patient's old red blood cells floating around, giving us this anti-A forward typing. And for the reverse typing, we would potentially have an anti-B, which we don't see anymore, right? Because the patient's plasma cells are being destroyed as a part of the chemotherapy and re-engraftment. Now, the new red blood cells will forward type as group B, and we're now starting to see anti-D form from the new red blood cells. So the green is new, and this blue are the old red blood cells. And so you can imagine that when you're thinking about this in a test tube, you've got A and B red blood cells in it, which means that when you're doing your agglutination, only one or the other is going to agglutinate when you're using these reagents, and therefore you get mixed field. So, as we've been describing, the production of group A red blood cells, no, because we're going from group A to a group B. Production of group O, we know that's not true. Production of group AB, we know that's not true. The person is engrafting with their new group B cells, which is what's giving us our new mixed phenotype. Now, a few months after the transfusion, so we would theoretically have full engraftment. The person would have gone from A neg to B pos, and they would look, hopefully, mostly B pos. The patient presents at an outside smaller hospital with a GI bleed. There's a request for 2 units of red blood cells with a type and screen ordered stat. What blood group do you provide in an emergency? So let's take a look at the forward and reverse typing. Forward typing looks like a B. Reverse typing still looks like a group O. RH looks positive, positive. So we have an RH positive. So forward, reverse, looks like we have a B pos. The reverse makes it look like, ooh, excuse me, my brain is not working today. AB, AB. So the question is, what are we going to provide? If we don't know what this person is, and you have to think about this, remember, in terms of what's going to be the most compatible with both of with both potential blood groups. The best thing you can do in this particular case, since they're both Rh positive, anything with Rh negative is essentially thrown out as an answer, right? Because we don't need to worry about the Rh. Now we have to think about what's compatible with each of them. A group A is not compatible with a group B person, so not going to happen. Group B would be compatible. However, we also don't know what's going on with this group AB in the reverse. We're either missing or adding an antibody, and therefore we can't resolve it. And we don't know if the group B red cells will be attacked by an antibody that we're missing, leaving us with group O pos, because that's the safest bet to know that it will be compatible and we will have no issues. So why did the patient not form that anti-A in their plasma or serum? Remember that the world doesn't just revolve around, as much as I would love it to, it does not just revolve around our red blood cells, right? So we have our red blood cells, and they express A, B, A. And with this particular individual, the only thing they're expressing right now is the group B. And so they have group B. Theoretically, they'd form an anti-A. That's, however, not the case because there are other organs involved, right? We've got the heart. Ooh, geez. The heart. That's my ugly liver. The kidneys, they all express ABO. And these organs were predating the transplant, right? So all these organs express the group A. So as a result, the human body is tolerized to group A and won't form an anti-A. Now, if you were to magically change the entire body over to group B, you could make an anti-A, but that's not the case. The only thing that's producing Really, group B in this particular case is anything coming out of the bone marrow, which in what we're talking about are red blood cells, but everywhere else in the body there's group A being expressed. So the body doesn't see group A as foreign. So why is it that it does not? Group A is expressed in other parts of the body. AB antigen is not expressed only on red blood cells. The AB antigen is not expressed in other parts of the body. So we're not talking about the A and B antigen, right? The B antigen is only being expressed on the stuff coming out of the bone marrow, but it's not expressed on the organs. And the A antigen is only expressed on the red cells. False, because they switched over to their new blood group, so it should be only group B. So that brings us to the end of our tier 1. I'm sorry for the little bit of rambling and free thought there at the end. I was just trying to make sure I captured everything. We'll be getting to tier 2 and tier 3 in the next few days, releasing them in a staggered format so that you have time to finish them. And I look forward to any feedback or questions you have.